going to give you examples of NCLEX prioritization questions that indicate changes in electrolytes that you have to prioritize and be sharp about. So let me show you examples of how this can apply to the NCLEX, where they can give you questions. They don't tell you it's electrolyte problem, but you have to figure out that it's electrolyte and you have to use it to prioritize your patient. Who do I see first? Okay, a client with hyperparathyroidism and the calcium of that. You see calcium of that, this is high. Okay, fine. But patient has hyperparathyroidism. You expect their PTH to be high. When the PTH is high, you have calcium that is high, and then phosphorus that is high. The trick is they're not telling me anything. I know this calcium is high. It's very attractive. I need to pick him because it's high. The number is too high. My brain is telling me it's too high. But guess what? They've not told you anything about whether the patient is symptomatic, is having a cardiac history, is having a GI symptoms, is dehydrated. They've not told you anything. There's nothing in the answer choice that tells me. The only thing it tells me is high PTH and a high calcium. And I said, well, that is what is expected. If you have hyperparathyroidism, your calcium should be that. Therefore, I know you have a problem. I'm not picking you. You are not my priority right now. A client with lung cancer and a urine specific gravity of that. You say, well, what are the pathways? Lung cancer, urine specific gravity of that. Then you ask yourself, how does lung cancer relate to urine specific gravity? There is a couple of lung cancers that secrete ADH. We call them small cell lung cancer, small cell lung cancer. So they have high ADH. Okay, what does the ADH does? ADH absorb water. Okay, so you absorb all the water, and then your urine output is going to decrease. When your urine output decrease, your urine is going to get concentrated, and all electrolyte in it is going to go high. Specific gravity of your urine is greater than 1.030. The normal range is 1.003 to 1.030. Your urine is concentrated, therefore it's greater than 1.030. This is 1.033. So the patient is in SIDH. So this is SIDH, causing the specific gravity to be that concentrated. What does the complication from SIDH? This is what you have to ask yourself. Is hyponatremia. So their sodium can go low to like 125. They can go low, but sodium is less than 135, of course. At least it's less than 135. And therefore, this patient is hyponatremia. Hyponatremia is the most dangerous electrolyte between hypo and hypernatremia. Low sodium is worse than high sodium. And low sodium. And low sodium, the problem is they go into seizure. So seizures are the number one problem. That's why we treat this. Therefore, I got to worry about this for now. So this is my priority. And I have to see this patient first. Okay? The way I said this question is not like you comparing each answer choice. This is multiple SATAs in a priority. I'm just giving you an example. So we'll get multiple answers. So this patient, I need to see him, is my priority because he has hyponatremia and then he's going to get sick from it. A client with sodium of 148 and receiving D5W. What is sodium? It's too high, right? And what is the treatment of hyponatremia? Free water. You give them free water, you let them drink it, or give them D5W to dilute it, to bring it down. They're not telling me I'm diluting it too fast. The other problem with this is you got to bring the sodium down slowly. So they're not telling me anything. So this patient is fine. He's getting treated for his problem. I'm not worried about him. A client on furosemide and then potassium of 3.6. What does LASIS does? It lower your potassium, okay? And their potassium is 3.5. It's still 3.6. It's still in the normal range, but it's in the low normal. This is an expected finding, so I'm not worried about it. It's 3.6. It's still normal. It's supposed to be low, but it's not lower than 3.5. So, and the patient is on LASIS, therefore I'm fine. A client with acute pancreatitis and a serum calcium of 8.7. What is going on? The acute pancreatitis causes hypocalcemia because the pancreas absorb all the calcium and form what we call soap. It causes saponification from the fat of the pancreas burning itself, then it suck all the calcium in the system. They have hypocalcemia. This is low normal of calcium. Therefore, this is unexpected. So the only person you're going to see is that person. I have to worry about this patient. Okay, this is the patient I will see first because it's worrisome. Okay, and that's how you analyze it. That's how you analyze this question. So let's try it. The next one. Which of the following patients should be seen first? Okay, a client on spironolactone and the potassium of this. Spironolactone, you ask yourself, what is the buzzword here? This is potassium sparing. So it increases your potassium. Patient potassium is what? 4. It's normal. It's going to increase it, but it's normal. It has not increased it. They give him 4.0. I'm not seeing the patient. There's nothing for me to worry about this patient. A client with chronic renal failure and a calcium of this. What is chronic renal failure? Well, the kidney is where most of the time you absorb calcium. So patient with chronic renal failure, their calcium is low. So, and their phosphate is high. So you need to give them some calcium. His calcium is low normal. This is unexpected. So I'm not worried about you. A client with NG tube output of 3 liters for 3 days. I know you see 3 and 3. Get yourself and think about it. NG tube. What does the NG tube does? So let's analyze it. So NG tube, when you have NG tube, the output that come out is mostly acid. You're losing sodium chloride, and hydrogen chloride. So you lose all the acid out, okay? And therefore, what happens is your body will have more bicarb, so increase bicarb. Right? And therefore, what happens? Your body will say, hey, mine's now I'm in metabolic acidosis. Okay, I've lost metabolic acidosis. I need to, and my sodium has gone. I need to take care of my sodium, and you get dehydrated. So the patient is dehydrated. I need some sodium. So your kidney will say, well, let me absorb sodium back. So kidney absorb the sodium, and what does it do? Get rid of the potassium. So these patients, they have this metabolic problem. They have hypo, sodium is low, low sodium, low potassium, and metabolic acidosis. So you have to control the electrolyte. This is the electrolyte problem they have. They dehydrated. Somebody is having 3 liters every for 3 days, continuously 3 liters per day. It's a problem. This patient needs some potassium, so you need to replace it. So it's a priority. So 3 liters of NG output for 3 days. It's getting each, so this is like each day. If the question is not clear, it's getting, what I was trying to emphasize is um, patient is getting 3 liters each day, okay, for 3 days, total of 3 days. So every day is getting 3 liters, that's a dehydration, and patient is going to be hypokalemic. And so you need to take care of them by replacing their potassium. And so this patient needs to be seen. A client with alcoholism and magnesium of 1.57. Patient who is alcoholic, they are more nourished. That's the key you can connect. More nourishment is the number one cause of hypomagnesemia. But this is low normal, so that's fine. You expect them to have a lower level of magnesium. So this is an expected finding for an alcoholic. A client 1 hour post-op from transsphenoidal hypophysectomy and receiving desmopressin. A bunch of words. Take ownership of the question and rewrite the answer choice. What does it tell you? Patient has 1 hour, just had surgery. What is transsphenoidal hypophysectomy? Trans, going through something, phenoidal, that means your nose. Your nose is your phenoidal portion of the face. And then, so going through your nose, hypophysect is the pituitary. So they went to your nose, they get to your pituitary, they remove your pituitary. Okay, now the patient is getting what? Desmopressin. It doesn't matter. All this patient has what? Brain surgery. You can change it into what? Brain surgery, and is getting desmopressin. Why would anybody who have brain surgery get desmopressin? Then you tell yourself, any number one cause, common cause of diabetes insipidus is brain surgery. So when you have brain surgery, you disrupt the pathway where you secrete ADH, so your ADH will go down. When your ADH go down, what happens? You start to pee a lot, so urine output goes up, and you get dehydrated, and you become diabetes insipidus. How do you treat diabetes insipidus? Give them their ADH back. And well, desmopressin is a synthetic form of ADH. So that is why this is right. There's nothing for you to worry about them. They have this fancy surgery. All it means is they had brain surgery, but that is transsphenoidal hypophysectomy is the removal of the pituitary, and therefore you expect them to have hypo and low ADH. So they will go into DI, and so you have to replace it. So I'm not worried about you. So there's only this patient you got to worry about. Okay, so that's another one. This is my fancy one. Which of the following patients should be seen first for medication administration? So patient need to be seen is getting medication, select or apply. Okay, he's getting medication, and I need to see them first. I rewrite them. I have my buzzwords. I've analyzed it. I'm looking for somebody. He needed medication because of his condition, and I need to see them first. If I don't go, they get into trouble. So a client on bumetanide and the potassium of that, you ask yourself, what is bumetanide? This is a loop diuretic. This is the same thing as the last name, okay, furosemide. It's the same thing. And therefore, they will have what? Hypokalemia. Your potassium is low. Look at this patient. His potassium is 3.4. Why would I have to give him a medication that will going to make his potassium low? Therefore, I'm not seeing you. I know you need your bumetanide, but I'm not giving it to you because your potassium is 3.4. I don't need to see you first. I have time. I will have to wait and check another lab and make sure your potassium is normal before I can give it to you. That is how you are being sharp. You are not being an expert. You are being sharp. You say, no, I know something about potassium that is 3.4. What is it? It's 3.4 is not good. It's a cardiac problem. Then you look at the situation, patient is taking something that will make their potassium even worse. Therefore, I have to be sharp. I'm not giving you your medication. I'll come and see you later. A client with cirrhosis on spironolactone and the potassium of that. Cirrhosis, they have ascites, they put them on spironolactone. It's a diuretic. You get rid of the fluid, and then they get better, the ascites. But then spironolactone is what? It says potassium sparing. So it spare potassium, so it makes the potassium goes up. Therefore, patient potassium is what? 4.5. Fine. It's still normal. I know it's a little bit high, but it's in the normal range. It's not 6, it's not 7. Yes, I'm not going to worry about it. Don't just get distracted. So far as it's in the normal range, 4.5, yeah, I'm not, I know you're taking it, but I give you 4.5. So that's what you have. If they give you 5.5, yes, 4.5, you don't have to worry about this patient. A client with diabetes insipidus on desmopressin and a sodium of 140. Ask yourself, what is DI? DI is when you pee a lot of water, they cannot absorb water, and they have no ADH. And what happened to DI patient? If they're losing their water, so urine output is high, therefore they get dehydrated, their serum sodium shoot up. It's greater than 145. The treatment is to give them ADH, okay? So they need an ADH. This patient is getting ADH, that's desmopressin, right? What is the sodium? 140. It's back to normal. It's not 150, 160, 170. It's 140. So I'm good. I have good therapeutic effect of the medication. I'm not worried about you. A client with this and a magnesium of that. You know, magnesium is low normal. It's still normal, but it has this. What do you see this? This is the EKG, and you have polymorphic ventricular tachycardia, meandering features. It goes up, then it comes down. It goes up, it's come down. It has a meandering features. It doesn't have the classic VTAC like that. And you can see the keyword is magnesium. And so this is my favorite. It's due to QT prolongation, and that is called Torsades de Pontes. So patient has Torsades de Pontes. Therefore, even though their magnesium is 1.7, is almost normal, but it's low normal, I need to see this patient. He has a symptomatic hypomagnesemia, and I need to do something. I'm not worried about the level now. Patient are now has symptoms. Yes, Torsades, this is a lethal problem. If I don't do anything, it's a problem. So I'm picking this choice. A client, 48 hours from thyroidectomy on calcium carbonate and a calcium of 8.6. So they remove the thyroid. Whenever they give you thyroid, think about hypocalcemia. Every time somebody had surgery and they remove their thyroid, the number one complication is hypocalcemia. So they need calcium supplement. They did not remove parathyroid, but they removed the thyroid by the complication of thyroidectomy. When you remove the thyroid, you end up injuring the parathyroid, and their level goes down until they recover. So you need calcium replacement. Its calcium is 8.6. It's low normal. It's still normal. It's not 9. It's still normal. I'm not going to worry about it. I'll give you your calcium, but I don't have to worry. You have some time, okay? So this is the only patient that I should take care of quickly. So you guys seeing the features that they can ask you. These are the things you should be seeing as we continue to do it. This may be the last one. Which of the following should be seen first? Okay. A client with CHF, okay, is on what? Eplerenone, okay, eplerenone, and none. And a potassium is 3.5. What is this? This is potassium sparing. This one and spironolactone, you got to know it. Eplerenone. They usually can replace the spironolactone because they know everybody know. This is potassium sparing. So your potassium goes up. Okay? Potassium sparing. Your potassium is 3.5. Fine. I don't need to worry about you. Your potassium is going to go up anyway, so I'm not worrying. A client with cirrhosis and a sodium of that. Cirrhosis, what happened? You have ascites. You hold on to water and you get hyponatremia. 133 still not that bad. Okay, it's still, but this may be the second patient you may have to see. There's no, it's not that dangerously low. But this patient is slightly low. 135 is a little bit 0.2, but you got to watch this carefully. I don't. Yeah, I will not see this patient right away if it's one of the questions, but it will be the second patient you see first. You see after you see somebody first. A client with malnutrition receiving initial TPN at half rate. This they can ask you. This is refeeding syndrome. So somebody with the TPN is malnourished. When you start feeding them, you want to give them half rate of the nutrition. If you don't do that, the cause is PPM. Their phosphate go down. Their potassium go down. Their magnesium go down. This is a lethal problem. And it's sad. Patient who is malnourished, you try to feed them and then you kill them. It's because you're giving them full diet. If they need 20 calories a day and you give them 20 calories, I know 20 is too low, but I'm giving you an example. If they need 20 calories a day and you give them 20 calories right when you start feeding them, you put them into what we call refeeding syndrome. You lower their phosphorus, you lower their potassium, and you lower their magnesium. These are dangerous electrolytes, and they go into respiratory distress, cardiac arrhythmia, and they die. It's a little problem. So you start their nutrition half rate. If they need 10,000 calories, you give them 5,000 calories initially, slowly, so that you avoid this. So this patient is getting appropriate treatment. I'm not worried about it. A client with bipolar on lithium with the sodium of that. I try to give you guys some knowledge-based content so that if you see somewhere in some of my questions, when I do questions, that's the way I do it. Lithium, what is going to cause? Fact about lithium, avoid dehydration. Avoid dehydration as much as possible. Therefore, what things you should avoid? Your kidney function should be normal. So creatinine should be normal. You should hydrate yourself, increase fluid. You should avoid hypokalemia, no hyponatremia, no hyponatremia. And those are the things. So you want to keep their sodium normal. You want them to drink a lot of fluid. And then you want their kidney function to be normal. Their sodium is 135 and they're taking lithium. I'm good. You don't need to be seen. A client with carpal pedal spasm 24 hours after thyroidectomy. Yes, they have thyroidectomy. We talk about it. Their calcium goes down. Symptoms of calcium going down is carpal pedal spasm. And therefore, this patient needs to be seen first. And this may be the last one. I'll let you guys go. Which of the following need immediate intervention? Okay. A client with Crohn's disease on salt substituent. What are these buzzwords? Crohn's disease, salt substituents. Okay. Crohn's disease is what you have a tumor that produces aldosterone. If you have too much aldosterone, you have high sodium. and you have low potassium. So you tell them to avoid salt. Don't take any salt, but taking some potassium. Salt substituent is a substituent of sodium. So it's a form of salt. Patient who shouldn't eat any salt, we give them salt substituent. The problem is he has low sodium and high potassium. So this is good for the patient. You don't want them to take any sodium and want some potassium. So this is you don't need to intervene with this patient, right? He's getting Crohn's disease, he's getting substituent. He's not taking salt, he's just taking substituents, which has potassium in it because you want them to get some potassium. So this is good. Good job, patient. The client with Addison disease on salt tab, okay, buzzword, salt, 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 salt. Then you ask yourself, what is Addison's disease? I have no steroid, or I have no aldosterone. So decrease aldosterone, what is going to happen? My sodium goes down and my potassium go up. Therefore, I should take sodium, I should avoid potassium. The client with Addison on salt tabs, yeah, he's taking salt tabs, not salt substituent. Those are the buzzwords. Salt tab, no salt substituent. Therefore, good job, patient. A client with small cell lung cancer on demycycline for urine output of that. We talk about it. Small cell lung cancer, it make ADH, right? ADH absorb water and it puts you into SIDH. The sodium is going to be what? Low. So you need to correct the sodium. But they tell you this patient is for demycycline. What is demycycline? Yes, demycycline is what block ADH. It has the same name, start with the D of desmopressin. Desmopressin is ADH. Demycycline block ADH. So I'm blocking the ADH so that I don't have to absorb water anymore. And that is the treatment, one of the treatment of SIDH. So this patient is he's getting the actual treatment that is needed. So he's getting demycycline for a urine output of less than 1 liter within 24 hours. So we treated him, we giving him appropriate medication. So this is good. Be careful, know them. Demycycline is not the same as desmopressin. Demycycline is for ADH, desmopressin is for DI. A client with AFib on digoxin, so there should be on here, on digoxin and cold medication for recent URI symptoms. So he's taking cold medication for URI symptoms, but he also has AFib and digoxin. Then you say, what is the combination? What am I trying to say? Digoxin, things you need to avoid. You should avoid low calcium. You should avoid, no, low potassium. You should avoid low calcium, high calcium, and then low magnesium. So once again, digoxin, avoid low potassium, avoid high calcium, avoid low magnesium, right? And so those are the key. Then the next one is anything that will create arrhythmia. You should avoid it. So you should avoid anything that will cause cardiac arrhythmia, because number one problem with digoxin is what? Cardiac arrhythmia. Cold medications, I see them as bad medication. All of them as ephedrine in it. Ephedrine. This will increase your blood pressure and it will worsen the cardiac arrhythmia of digoxin. So we need to tell them, you can't take ephedrine. They don't, you see, they don't say ephedrine, but there's code medication has ephedrine in it that will cause cardiac arrhythmia, hypertensive urgency, and that will be a problem. So I need to see this patient. A client on clotilidone, eating banana with each meal. What is that? This is diuretic. It's the same thing as ACTH. No, ACTZ. Okay, it's the same thing, hydrochlorothiazide. And so this patient, when you take hydrochlorothiazide, your potassium goes low. And this patient is taking banana. That's good. I want you to do that. And so I'm not worried about you. So this is the only patient you should worry about. And this is the end of it. I think I've given you multiple examples how the electrolyte aspect of it will play a role. All you need to do is just stay focused, know what you're looking for. You have to have a little bit of content, but the content doesn't have to be extensive, just enough content to figure out the keyword, the pathophysiology of the problem, and you can figure out the answer. Pathophysiology content. Be sharp and don't be expected. Take care of yourself, and as always, keep charging.